Dear Chairman and friends, good morning. So for me, it's really great honor to be the GIS International Board member. So the last year, about the November, so when I had the meeting in Indonesia, so that time, it's the same time I get news, so I'll be selected to be the GIS International the board member, so it's my great honor. So today, so it's, for me, it's the second time to be in Dubai. And about 4 years ago, I attended one meeting in Saudi Arabia. So that time I also in Dubai. When I go back to China, and 2 days later, so the COVID-19 started in China. So it's very impressive. Today, when I come back, I want to talk a lot, but I would like to say I'm very happy to attend this academic platform. So just now, I heard from the Professor Shehab, and in your slides, you say from the communication about the complication case through. So we will decrease the risk of the complication in our practice. So now I talk about the no reflow prevention and treatment. So it's about it's very early age. When I was young, the PCI operator, so I just heard the no reflow phenomena, but only when starts the PCI in AMI about the 25 years ago. So I have the one case, so it's very serious. But that time in Fuai Hospital, because Fuai Hospital is the National Center for Cardiovascular Disease, it's the biggest the center. So last year, our totally the PCI volume is the 23,000. So, but it's 25 years ago. So in Fuai Hospital, we have never seen no reflow. But I still remember the patient with my cardiac infarction is inferior the infarction. So the coronary show the total closure in the middle RCA. So after predilation was blown, so the blood flow is good. But after the first stent, so the blood flow, totally stopped. So some colleagues told me, so maybe dissection is the distal, you should put the second one. So after second stent, so still the no blood flow. And somebody told me, so you should put the third one in the proximal after the third one. So it's the totally, so it's the proximal RCA, it's no the contracts. So this is my first time, it's my first case. It's also the first case in Fuai Hospital, as the 25 years ago. But now there no reflow. It's, I think compared to before, now it's everybody to know how to prevent and how to avoid it and how to treat it. So regarding to the prevalence, so in the last 20 or 30 years, so the different the study report the different prevalence, because I think it's the different area and a different method to evaluate. And once the no reflow occurs, so it has the very strong the negative impact on the outcome. So I think it's for our first the case with the no reflow. So the patient after the PCI, so the patient received the IBP, also the pacemaker, and the patient stay in the hospital more than 1 month. So, but the progress is very bad. And regarding pathogenesis, so up to now, so we know, so underlying cause of the no reflow is the microvascular obstruction, so which may be produced, it's the different, the mechanism. And but it's so for the myocardial infarction, so we know, so no reflow can occur, but for the non-infarcted artery, it also can occur. So it's the different mechanism. And up to now, so we very simple, the angiographic evaluate the blood flow. So it's first step. But after the PCI, so there are also several methods to evaluate myocardial perfusion. And so here is the different method to evaluate, to diagnose the no reflow. And so here I just very briefly to review the risk assessment. So it's from the clinical factors. So the last years, the studies indicate maybe some clinical factors indicate the high risk for no flow during the procedure. But it's very important is the lesion composition. So everybody knows, so if the large vessel, it's the long lesion, and there is the big thrombus burden, and it's the plaque with the rich, the cholesterol. So it's very high risk for no reflow. And but with the years, IRIS and the OCT can indicate in detail about the mechanism for the no reflow. And sometimes we also use the physiological evaluation and to assessment the risk for no reflow. So now is the different, is already developed the different composite score to evaluate the risk for the inflow. So, but I think is here maybe I can talk about the personal experiments, and I think is to compare to treatment, the prevention is always first. So the strategies for the prevention is medication therapy, device-based therapy, and optimize the PCI procedures. The targeting of the different mechanism, so the medications that are provided such as adenosine, the calcium channel blockers, and the sodium nitrate peroxides, etc. So the medication is the first step to prevent, to avoid the no reflow. So maybe before the procedure, we can use some medications. For example, is the nitroglycerin, adenosine, and the TOB3 inhibitor, and maybe sometimes is the epinephrine, and through the intravenous or the intracoronary artery. And sometimes we also, before the procedure, we use the different antiplatelet drugs, and also the stent, the big doses of stent. So this is the different medications. And when the small, the earlier, it's very many years, it's very small, the study, it's the reflow study. So they test the epinephrine usage in the myocardial infarction. So because this is the small, it's very earlier. So this is the small, the trial, but it's indicated. So this medication that can be used to prevent the no reflow. So up to now, so we use the different medication like the serine kinase, and sometimes we also use the TOB3 A inhibitor to prevent the no reflow. And so this is very interesting. So this the TIMI, the 49 trial. So it's also small the trial, but it's the positive result with the coronary intracoronary thrombolytic. But in China, it's many medical centers, so they use the thrombolysis and then followed by the PCI. So it's good. So about 2 years ago, so it's the trial is published in circulation. And so now we use the medication depends on the different status after the balloon dilation. So some patients with the bronchocardium, some people with the hypertension, and some people with the bronchocardium. So we use the different medications. And when the study report, so the before the procedure, maybe the take Grada is much better than the Plavix. And another the strategy to prevent no reflow is the device-based therapy. And so now there are the different the devices. For example, it's manual thrombus aspiration, magnetic aspirin catheter, and laser atherectomy, and also the distal protection devices. And I think this 20 years ago, so when we used the device to prevent the no reflow, but it's the earlier studies, it's always negative. But I think it's that time because it's take time to manipulate the devices and prolong the reperfusion the time. So this is always negative. But now it's the most of the studies that it's positive. So this is a different. So some study also indicate so laser coronary thyroidectomy is also very effective. But this very important. I think is the next maybe the one of friends report the manipulation because it's the different manipulation maybe the different the risk of the no reflow. And here maybe I can tell the story. So and Dr. Yang, Professor Yang, I think maybe that he helps you know him, and he's very famous in China in the field of PCI. He's the older than me, but 7 years ago, 7 years. But he's very fast. So and his complication with the no reflow is the highest in Full Hospital. So that time I realized because the manipulation is too fast, so we tried to slow down. But we finally find, oh yeah, this is good. It's good manipulation. So now I think in the world, and everybody knows, so we should prolong inflation, deflation, and also the stating. So this is this is the optimize the PCI procedure. And if we find it's the big thrombus burden, so the before stating, so we aspirate we use the different device to decrease the thrombus burden. It's also very useful. And so this is I think this is the new achievement. About 2 years ago, so the studies suggest the unloading the method maybe used before the stent in some specific patient. For example, it's very high risk for reflow. So we try to use the unloading method and to prolong the time for procedure, and maybe it can decrease the risk of the reflow. Sometimes we also use the magnetic assist device, such as IBP or ECMO, that should be considered. And so this is the personal the sticks. So I use the ATP dilute with the contrast during the stent positioning. So we use the mixed the ATP and the contrast during the stent positioning and inflate stent. So it significantly decrease the risk. And so recently in China, we also use the Chinese traditional medicine before procedure. It's also can decrease the risk of reflow. Okay, thank you.